Hello, everyone. So here we are today with the next topic on ovulation stimulation protocols under RRR series. And it is pleasure meeting you all again with a nice topic, which is very important for the EFOG exams. So the topic today is ovulation stimulation protocols. Okay, and I'm Dr. Dhavashree, one of the mentors at StudyMEDIC, and I am here to present this topic. And we always love, starting off with a quote, and this is something very important. So you get what you focus on, so focus on what you want. So if you're focused, definitely we would be able to achieve what we want. So that's all about. And the session agenda is I would be talking to you all about the ovulation stimulation protocols. What is the difference between ovulation induction and ovulation controlled ovarian stimulation? Okay, ovulation induction is in a woman with an ovulation, we give medications, drugs that would stimulate the ovaries to produce one or two more eggs that can cause ovulation. That is ovulation induction. What is controlled ovarian stimulation? Controlled ovarian stimulation is the ovaries are stimulated in a controlled fashion so that we achieve a multiple number of follicles so that we would be able to retrieve it and then use it for doing an IVF or an ICSI. So that is the difference between ovulation induction and a controlled ovarian stimulation. So basically, controlled ovarian stimulation is done in assisted reproductive techniques. So what is an assisted reproductive technique? It's all the treatments and techniques that involve in vitro handling of human gametes or the embryos with an intention of achieving a pregnancy. That is what is called an assisted reproductive technology. So what happens in an ART? In an assisted reproductive technology, there is a pre-stimulation assessment. Then we do a controlled ovarian stimulation, which is followed by the trigger, which finally ends up in an ovum pickup or a oocyte pickup. And then embryos are made and then embryo transfer is done. After an embryo transfer, we give a luteal phase support. So these are the components of an assisted reproductive technique that usually happens. So let us talk about pre-stimulation assessment. What do we want to assess in the pre-stimulation assessment is we would want to identify whether a woman is what would be the response of the ovary of the woman to a particular stimulus. Okay, that is prediction of the ovaries to the stimulation. So we would want to know the response of the ovaries to a particular stimulation that we give. So what is that would help us in assessing the prediction? It's basically an antral follicle count or the anti-Mullerian hormone or an AMH. These are the two things which are recommended by the ESHRE over the other ovarian reserve tests. Okay, and they have got higher accuracy when compared to the other ovarian tests. The other ovarian tests include the FSH, Inhibin B, age. These all as a separate thing, they have some predictive value, but they cannot be used as one particular test cannot be used to assess the prediction of ovarian response. So only an antral follicle count or an AMH can be used to predict the ovarian response. Basically, each of them can be unique in their own, but when there is nothing like if we combine both, it increases the prediction. Okay, so each of them alone can be used as a marker for ovarian response. What are the other ovarian tests which cannot be used as predictors? Or basal E2, that is estradiol values, and BMI alone we cannot, though they may be able to help us in predict, they cannot be recommended as a prediction of ovarian response. So these other ovarian tests should not be used for prediction of ovarian response accurately. So what are those that are accurate that should be used what to predict the response accurately is the antral follicle count and the AMH. Okay, antral follicle count is the follicle count which are the small follicles which are seen on day 2 of the cycle, where they are usually less than 9 mm, 3 to 9 mm follicles which are seen in each ovaries. Okay, and AMH is the anti-Mullerian hormone, which is secreted basically by the preantral and the antral follicles, and usually they are the reserve. Okay, once they become a follicle, okay, which when it grows, they do not secrete AMH. So basically, to test the ovarian reserve, it is only the AMH which helps us in predicting the response, AMH or the antral follicle count. So to identify who is how do they respond, AFC or an antral follicle count or an AMH can be used. And let's look into how do we predict. Okay, so when we look at the antral follicle count, okay, when we look at with an ultrasound on a day 2, antral follicle counts are the number of follicles, as I said, between 3 and 9 mm. And if they are less than or equal to 4, okay, if we can see from both the ovaries, we are able to see only 4 on in both the ovaries, then we think we can assume that these women have a low ovarian response. And for women who have more than or equal to 16, then we can predict them as a high responders. And anywhere between 5 to 15 are the normal responders. Coming to AMH, okay, usually in ESHRE, we normally talk about, in European ways, usually it is represented in nanogram per ml. So normally an AMH of less than or equal to 0.75 nanogram per ml is considered to be a low response. And if it is more than 3.5, equal to more than 3.5 nanogram per ml, then it is considered as more than 3.5 nanogram per ml is considered to be a high responder. Anywhere between 0.75, that is 0.76 to 3.5 is considered to be a normal responder. And if we do not have, if it is given in picomoles, then to get it in nanomoles, it is multiplied by 0.14. It's just a number if you can remember. Otherwise, please do not worry. AMH is usually in European norms. We always look for that in the nanogram per ml. So coming to the ovarian, so what is that we will have to look at? So pre-stimulation, we look at whether the woman will respond. How does a woman respond, so that we can have an individualized stimulation protocols. Okay, so when we talk about ovarian stimulation protocols, we will have to look at how do we stimulate the ovaries. The stimulation of ovaries is basically, let me talk about the basics of ovarian stimulation. So when there is an ovarian stimulation, always there is the follicles grow, which releases estrogen. When the estrogen increases, what happens is the LH starts increasing. When the LH starts increasing, this is in a normal cycle. Okay, when there is a follicle growing and the follicles grow, it produces estrogen. The estrogen actually causes an LH surge, which causes the maturation of the follicle, thereby the follicle rupture. This happens in a natural cycle. What happens? What is that is different in controlled ovarian stimulation is, let us know about the basics of the controlled ovarian stimulation. Here, we are particularly willing to stimulate the ovaries so that we get a maximum number of follicles from the ovaries. So the basic idea is stimulate the ovaries to produce multiple follicles, which is achieved by giving gonadotrophin. So when we give gonadotrophins, they basically act on the ovaries and they make the ovaries produce follicles. And when the follicles grow, when the follicles develop, this follicles, they produce estradiol. Estradiol, when it reaches a particular value, it causes an LH surge. So what happens in a controlled ovarian stimulation is there is a quick. So even when there are multiple number of follicles, there is a higher supraphysiological levels of E2. So even when the follicle is around 13 mm, okay, there might be a very high estrogen which can cause a premature LH surge. So we may not be, when there is a premature LH surge, we may not be able to achieve a good follicle. Okay, so that is the reason why we need a LH suppression. So to prevent the LH surge, so what we do is we can do two things. Okay, so how do we prevent an LH surge? This is to prevent the follicle going through earlier maturation, even before we get a good follicle. So to prevent the premature LH surge, we can use two things. One is a GnRH agonist. Okay, so depending upon what we use, whether it is an agonist or an antagonist, we call that as a agonist cycle or an antagonist cycle. So when we use an agonist, what does a GnRH agonist do? GnRH agonist, basically it causes a flare. When we give an agonist, it goes and attaches to it works at the pituitary, hypothalamo-pituitary level, where it acts on the pituitary, thereby it causes a flare of the gonadotrophins. Initially, when we give an agonist, there is always a flare of gonadotrophins, which is followed by down-regulation of the receptors. So there will not be enough receptors which can be stimulated by the estrogen, by the gonadotrophins. So basically what happens is, when there is a high E2, there will not be any, the GnRH agonist suppresses the receptors, thereby it depletes the receptor so that there is a down regulation of the gonadotrophin releasing hormone receptors. So this causes a depletion. Okay, thereby whatever we give, there may not be any FSH or LH secretion. So when a agonist is given for a long time, it basically suppresses the LH surge. Okay, that is the reason why we normally in an agonist cycle we start it before the previous cycle. Okay, that is what is called the agonist cycle. So this is the one way of suppressing the LH. The other way is, when we start giving gonadotrophins, the follicles grow. So when they reach 13 mm, there can be a physiological increase, okay, of premature LH surge. So to prevent that, we can give antagonist when the follicle is around 13 mm. That is what is called an antagonist cycle. So the basic idea is, when we start giving gonadotrophins, the follicles develop and we don't want it to rupture. Premature LH surge should not be there. That is the reason why we need an LH suppression. Okay, so when we give an LH suppression with a gonadotrophin effect, this follicle keeps growing, and when it reaches an appropriate sizes of around 18 mm, 16 to 18 mm, we give, because the final maturation is actually triggered. Okay, how do we trigger the final maturation? It is either by giving a HCG injection or an agonist trigger. Okay, basically an agonist is something which causes an FSH and an LH surge. So this is basically to mimic an LH surge. HCG has an LH surge kind of activity, and agonist trigger also has an LH surge. So basically the final maturation, though we have suppressed the LH suppression, we have caused an, either by giving an agonist or an antagonist, we have caused an exogenous suppression. The suppression is given from outside, but again, this can be overcome by giving a trigger with a HCG or an LH surge. Thereby, we can achieve a final maturation. I hope this is clear so far. So let me make it simple. Let me make it even more with a diagram. I'll show you in diagram. So what is meant by, what is that drugs that, or medications that we use as an agonist and antagonist is, GnRH agonists are that is commonly used is leuprolide, triptorelin, buzerelin, gozerelin, and naferelin. Okay, the commonly used ones are the leuprolide and the triptorelin. And GnRH agonists which are used to suppress LH suppression is either a cetrorelix or a gamarelix. Okay, so both the agonist or antagonist is basically used to suppress the the premature LH surge. Okay, so the cycle, what we call an agonist cycle or an antagonist cycle, is depending upon the medications that we use to prevent LH surge. So when we say agonist cycle, an agonist is used to suppress LH surge. When we say an antagonist cycle, we use antagonists to prevent LH surge. I hope it is clear so far. So let me move on to explain the important protocols. So basically, when I said GnRH agonist protocol, it's always this is a conventional protocol, which is a long agonist protocol. So what we do is, see, normally this is day 1 of the cycle. Okay, the cycle before. Okay, so this is the reason why in the previous cycle from day 21 we start giving GnRH agonist. Okay, GnRH agonist is basically leupride. Okay, we give leupride from the day from the 21st day of the previous cycle, so that even if there is an initial flare, when we give on a long term, it causes a suppression, okay, down regulation of the receptors, thereby totally suppressing the LH. It will prevent the LH surge. So if these, when this is given for a longer time, it causes suppression. And when the patient gets the periods, okay, so depending, even if we give an agonist, it would not prevent the woman from having menstruation. Usually she has a menstruation, and if she has from day 1, we can day 1 or day 2, we start, usually from day 2 or day 3, we start the gonadotrophins. And when we start the gonadotrophins, they cause the ovaries to respond by producing follicles, which would cause estradiol to go up. So here there is already a suppression. So even if the estradiol goes up, there will not be any premature LH surge. So when we keep monitoring the woman either by ultrasound, most probably with an ultrasound, and the estradiol values. And once the follicle is around 16 to 18 mm, we give a trigger. Okay, either usually in an agonist cycle, it is always a HCG which is given, and HCG is the culprit for OHSS. So for a woman who is a high responder, HCG should not be given because it might cause OHSS. So basically, for women with high responders, agonist protocols are not a preferred ones. Okay, so when we give HCG, normally HCG causes a final maturation, and 35 to 36 hours post HCG administration, we do a oocyte retrieval. Okay, so this is what is the gonadotrophin and GnRH agonist protocol, or the long agonist protocol, or the conventional protocol. Okay, so let us move on to the other protocols which are usually used. Here the next is antagonist protocol. In antagonist protocols, we have 2 protocols, either fixed or flexible. Please do not worry about whether to use a fixed or a flexible. The basic idea is you give gonadotrophins from day 2. Okay, in both we start giving on day 2, and in fixed protocol, whether the size of the follicle has become 13 or 14, we have to start her on antagonist because we expect the E2 to be, estradiols to be high, which can cause a premature LH surge. Okay, so a fixed, either we can start on day 6, which is a fixed protocol, antagonist is started to prevent an LH surge, or in a flexible protocol, we can keep looking at the ultrasound, and once the follicle is around 13 to 15 mm, we can start antagonist on that day, because usually 13 or the 14 mm is the time when the E2, when the LH surge starts, premature LH surge starts. So to prevent that, we can start gonadotrophin antagonist in a flexible way by looking at the ultrasound and starting depending upon the size of the follicle. Okay, and it is continued, and gonadotrophins are also given to make the follicle grow, and the gonadotrophin antagonist is given to prevent the premature LH surge. So once the follicle has reached around 16 to 18 mm, and HCG trigger can be given, but suppose HCG trigger can be given to cause an LH surge, or if the woman is a high responder where OHSS is expected, in such women, in an antagonist protocol, we can give an agonist trigger so that we would make OHSS become 0. Okay, so nowadays we run clinics at 0 OHSS clinic. Okay, so we don't want OHSS because it is something which is iatrogenic. We do not want something to happen. So it's always good to avoid HCG and give agonist trigger in case of antagonist cycle to prevent OHSS. Hope it is clear so far. Yes. So let us look into what kind of stimulation should we start in case of a high responders. We know high responders have a high chances of going in for OHSS, especially women with PCOS or women who have had previous OHSS or women who have had high response in the previous cycles. These are the women who should have an antagonist protocol. Okay. So antagonist protocols basically prevent, reduce the chance of OHSS, but the other way by which we can completely take away OHSS is by giving agonist trigger for an antagonist protocol. Okay, suppose for some reasons, usually agonist protocols are not recommended for high responders, but in case if high responders need agonist, if we are going to think of agonist protocols, then probably we should reduce the amount of gonadotrophins that are recommended, that is to be given to a woman, so that we reduce the risk of HSS. But for a woman with high responder, generally it is only the GnRH antagonist protocols which are recommended. Okay. So let's move on to the normal responders. Normal responders are with women who would respond normally. So based on the AFC and EMH, we would categorize these women into normal responders. And for this woman, always for normal responders, antagonist protocol is a recommended protocol. So for women with high responders or normal responders, always antagonist protocols are the one which are recommended. Okay. In case of women with high responders who are at risk of OHSS, antagonist protocol with an agonist trigger is to prevent OHSS. Okay. Hope I'm clear so far. So coming to the poor responders. Poor responders are those for whom we can use both agonist protocol or an antagonist protocol. Both are equally recommended for poor responders by Dhavashree. Okay, so these women can undergo any of this, both agonist or antagonist, because it does not cause any much of difference in the outcomes. The other, for poor responders, the other stimulation protocols can be mild stimulation with only CC. It can be combined with gonadotrophins, or gonadotrophins alone at a low can be used. And basically, these women, even if you use a higher dose of thinking that these women will respond for a higher dose, generally, Dhavashree says it is unclear whether higher doses over 150, okay, 150 international units is recommended for poor responders. But the thing, beyond 300, we should not recommend beyond 300 international units of either an FSH or a HMG to stimulate in case of poor responders. So in poor responders, it's both the agonist or the antagonist which are equally recommended for poor responders. Okay, so coming to the gonadotrophins, which gonadotrophin should be used for a controlled ovarian stimulation is, we can use either a recombinant or a HMG. The only thing is recombinant has a batch-to-batch consistency, but otherwise we can use Dhavashree recommends equally. We can use either an FSH or a HMG. They can be equally recommended. In case of agonist cycles, we can use anything. It can be a recombinant FSH, it can be a highly purified FSH, it can be a purified FSH, or even a HMG can be used in case of agonist cycles. Okay. Use of recombinant FSH and recombinant LH is not recommended, because if we use both recombinant, the chance of OHSS increases. So generally, recombinant LH and recombinant FSH are not used together. So it's either an recombinant FSH or you can use a HMG. So coming to the, as I said, when there is a stimulation, there is always a increase in estrogen, which causes a premature LH surge. This LH surge is to be suppressed. That is what is basically we are very interested, based on which we name the protocol. In case of GnRH antagonist protocol, see what happens is GnRH antagonist protocol is preferred normally for an LH surge because we don't have to give from the previous cycles. It is a long process. So basically for an LH suppression, it is always GnRH antagonist protocols which are preferred. So it can be either started from day 5 or day 6 or based on the cycle, which can be named as a fixed protocol or a flexible protocol. Whereas GnRH protocol for GnRH agonist protocol can be used for LH suppression, but that needs suppression from the previous cycle. So GnRH agonist protocols is probably recommended over the other short or ultra short GnRH. There are other protocols like that of, instead of long suppression, can we give a short suppression? But SRH recommends only a long agonist protocol over a short or an ultra short GnRH agonist protocols. Okay. So let's move on to questions. Let us just, with whatever we have here, let us look on to the questions. Okay. So here, the options are given here. Identify the appropriate protocol of the picture given. Each option may be used once or more than once or not at all. This is an EMQ. So what happens here on day 2, we have started the stimulation with gonadotrophins. And we have started on day 7 or day 8, we have started GnRH antagonist, that is cetrorelix or Yalorelix. So what is this protocol called? Yes, it is GnRH antagonist protocol. Okay, here it is a flexible protocol because we have not started on day 5 or day 6. So based on the size of the follicle, they must have started. So I've just put it as, just for your more clear thing, it is antagonist protocol, which is answer A. Okay, so coming to the next, what is this? Here, this is the cycle day 1. Here we have had a menses, but agonist has been started before. So this is an agonist which has been given, followed by we have started gonadotrophin. So the suppression has been started from the previous cycle. So what is this protocol? This is a long agonist protocol. Okay, so hope this is clear with the kind of protocols. Let us look into questions. Okay, scenarios. So let us find out for whom what kind of protocol we would use. So for the scenarios given below, choose the most appropriate stimulation protocol. Each option can be used once or more than once or not at all. So the options are given. Please do not read the options first. Always read the stem and look for the most appropriate. Here it is the most appropriate stimulation protocol. Okay. So the question here is, a 42-year-old woman presented with primary infertility and married for the past 7 years. Her BMI is 20 and her AMH is 0.7. So what does this mean? Age is less, age is more, but here AMH is 0.7, which means it is low. AMH is low, so she might be a low responder. FSH and LH is not used to look at whether she is a high responder or a low responder or not normal responder. But here FSH and LH seems to be normal. Her antral follicle count on the right is 2 and the left is 3. So which means that the antral follicle count of less than 4 is low responder. But here the age is more and AMH is low. So she is probably a poor responder. And what is the best protocol that can be used for poor responders? Yes, poor responders, both agonist or antagonist can be used. So the answer is D. Agonist or antagonist protocol can be used. So GnRH agonist or antagonist is equally recommended for predicted poor responders. So coming to the next question. Yes, here This is the most appropriate stimulation protocol which we will have to choose. A 32-year-old woman with bilateral tubal block had a miscarriage after the second embryo transfer. The first ET failed. So she's had 2 embryo transfers and it was all for tubal factor. Okay, so she has undergone a previous IVF and had an early onset OHSS during the previous cycle. Okay, so it means she is at risk of developing OHSS. So she is of young age and now she is going through a second IVF. Her AMH is 5.46 nanograms per ml, which means she is a high responder. Her BMI is 33 and FSH is normal, LH is normal. Her antral follicle count on the right is 11 and on the left is 12, which put together it is 23, which is a high responder. So for a high responder, what is the stimulation protocol that should be used? Yes, it is antagonist protocol. The answer is here antagonist protocol, but what is she at risk of? She is at risk of OHSS. So what do we do? The best answer would be an antagonist protocol. Look for the other answers. Here there is an antagonist protocol. Here there is an antagonist protocol with a HCG trigger or an agonist trigger, which is actually not right. The other option is antagonist protocol with the agonist trigger. So the answer would be antagonist protocol with an agonist trigger. So basically for high responders, it is only an antagonist protocol which is preferred, and the women with risk of OHSS, antagonist protocol along with an agonist trigger makes it a nil chance of getting OHSS. Hope it is clear so far. The next question is, choose the most appropriate stimulation protocol from the list of options given below. Here, this is a 33-year-old woman with a primary infertility of 5 years with a BMI of 24. And AMH is 2.4 nanogram per ml, which is actually normal. 0.7 to 3.5, here it is normal. And antral follicle count on the right is 6 and on the left is 6, which means it is 12, which is again a normal responder. And FSH is normal and LH is normal and is undergoing IVF for a male factor infertility. What is the best protocol that is recommended for uncontrolled ovarian stimulation? This is a normal responder. For a normal responder, always antagonist protocol is the one which is used. The answer is B, which is antagonist protocol. So here, if you see, the answer should be, let me change, it's not EF. So it is B, which is the answer here. So basically, the answer is the antagonist protocol, which is used for the normal responder. I hope I have made things clearer, and if any queries, please reach out to us so that we would be able to help you. Okay. Thank you all for listening to this, and see you all again with another new topic. See you all, and all the best to every one of you. Thank you.